Good afternoon, everyone. This is Anna Bartels at ASTO, and thank you for joining us for our August Integration Forum Workforce Committee call. And I'm pleased to introduce our chair, Dr. Randy Wyckoff, and turn it over to him.
Thank you, Anna, and welcome, everybody. Later in the call, we'll ask folks who are new to introduce themselves. Before we start, just a couple of reminders. If you've got the agenda, you can click on the webinar link at the top, the Ready Talk link that will allow you to see the slides as well. Please feel free to type questions in on the side where the question section is, and if you don't mind, keep yourself on mute so that we don't have the background noise. And please be reminded that the call is being recorded. Before we begin with the agenda, I suspect most, if not all of you, know that public health lost one of its great leaders and friends about a week ago. Harrison Spencer, the president and CEO of ASPPH, passed away tragically and unexpectedly. I think most of you knew Harrison. He had an incredible career in public health, both domestic and internationally. He'd been the dean at Tulane, dean at the London School, and for 16 years had been president and CEO of the Association of Schools and Programs of Public Health, arguably at the greatest time in the change of public health education in at least 100 years. And just a remarkable person. There's information about a memorial service on the website, the ASPPH website. It'll be on September 9th. The organization, of course, will continue operating. Allison Foster will be the acting president, and there will be a search committee that will be chaired by Donna Peterson. There's also information on the website about how you can communicate your sympathies to the family. So I know we all are incredibly saddened by that. Very pleased, let me go on with the agenda then. We're very pleased today to have Dr. Rob Pack, Professor of Community and Behavioral Health and the Associate Dean for Academic Affairs here in the College of Public Health. More relevant to today's call, he runs the Center for Prescription Drug Abuse, Misuse, Prevention, and Treatment. And everybody on this call knows that this is a tremendous public health issue, particularly in our region, but growing around the country. If you don't know, East Tennessee State is in the middle of Central Appalachia. Rob has put together a really remarkable interprofessional, intercollaborative project. So he's going to talk a little bit about the state of the issue, but then also talk about some strategies that they have that hopefully would be informative to you all. So at this point, I'll turn it over to Rob.
Thanks, Randy. I also just want to say to my colleagues at ASPPH or others that knew Harrison, just how sorry I am about what happened, and it is a tremendous loss for academic public health as well as public health practice. So our thoughts are with you all. So today I'm going to tell you a little bit about the epidemic nationally, but also a bit, really, I guess, more in depth in Tennessee, the epidemic of prescription drug abuse. And I'll talk some about the context of what has been happening in Central Appalachia and in Tennessee, and then I'll also mention what our approach has been to address this issue. And at the end, I'm hoping that we can have a conversation about maybe some strategies that you've seen that might work, or maybe if you have some other ideas. So I'll start here. There we go. Okay, so according to the MMWR 2014, this is a July 2014 MMWR where we were in Tennessee ranked second in the #1 country in the world in terms of opioid consumption. And when I say second, we were off by 1/10 of a percentage point in front of Alabama. So we're well up there toward the top in terms of opioids consumed, dispensed, prescribed, dispensed, and consumed. All right. And then in that state, where the second most dispensings and consumption happens, East Tennessee is far away the number one area in our state. So we have a huge problem. We actually have some interesting data on consumption by county that normally I would show, but we recently learned we have some problems with the vendor for the denominator, and we're going to embargo those slides until we get those issues controlled. So I will show you this in terms of consumption in the state. So milligrams of morphine equivalent are a standardized unit, and it's basically a way of looking at for example, fentanyl is much stronger than hydrocodone, and so it's a way of standardizing everything into one unit, right? So MMEs have been decreasing in the state, and this figure, the purple bar, as far as opioid MMEs, is 2012, and then 13, and then 14. But in 2012, that's about 8 billion MMEs dispensed and reported to the Controlled Substances Monitoring Database in Tennessee. It went down to about 7.5 billion. And then you can see to the right the drug that is frequently used here in Tennessee and is being promoted for use nationally, buprenorphine or Suboxone. Buprenorphine has been increasing steadily as opioid MMEs have been decreasing. So that's actually a good sign. That buprenorphine MMEs increasing is actually a good sign as long as that buprenorphine product isn't being diverted, and that's something we'll talk about here in a few minutes. So problem is we have a tremendous number of overdose deaths, and that is causing a lot of people to really take a hard look at this problem now, finally, because a number of us have been looking at this for a while and saying, hey, we need to do something about this, but at this point, you simply can't ignore the number of overdose deaths, and that is at this we've actually crossed over past motor vehicle accidents and as the number one cause of unintentional or death from unintentional injury, and that happened a few years back. In Tennessee, we've actually been seeing a strong rise in overdose deaths, as you can see here. Methadone deaths have been largely flat and typically not caused from replacement therapy or methadone management therapy. It's actually, these tend to be from methadone used for pain control from pain clinics. And you can see the increase in heroin across the bottom from 18 to 147. So, you can, upward trends are unfortunately what we've been seeing in this entire epidemic. This slide is a slide from the CDC that was initially, it was in the PowerPoint, it was a layered set of slides from 99 to 14 showing the progression of the problem. But since we're in the sort of the way the slides are being presented right now, I'm going to skip past this and go to the next one, which will illustrate really where we were and where we are now. So this illustrates drug overdose deaths in 2002, and sort of red is worst. In fact, red, the darkest red, is greater than 20 per 100,000 in a county. And you can see in 2002, there's a little cluster of it's actually 23 contiguous counties in 2002, all in central Appalachia, that had overdose death rates of greater than 20 per 100K. Out west, there were also some counties, those were single counties out west, where the overdose death rate was also high. You can also see in the 2014 data how the rest of the country has unfortunately caught up at this point. And unfortunately, it's a tragic circumstance, but it is our grim reality. Especially here in Northeast Tennessee, this is what we're dealing with at this point. This is our 8-county region in Tennessee and then 3 counties across the top are really what we at the center consider to be our if you will, catchment area. And this is the area for which we proposed our opioid treatment program, our outpatient opioid treatment program, about which I'll speak in a few moments. But here in Central Appalachia, this is unfortunately a story we hear about frequently. I don't know if you heard the news yesterday or the day before, but this was reported in Huntington, West Virginia, which is sort of northwest of here by a few hours. Huntington actually had 26 overdoses in one evening, centered around just a couple of streets. Now, all 26 of those individuals were revived. 10 of them were revived using the drug naloxone or Narcan, which is a kind of the overdose reversal drug, and it's a useful tool. 10 were revived using that. The remainder were revived using sort of breathing bags, if you will, because people's respiration had decreased to the point where they couldn't breathe on their own. That's a dramatic story, and I'll tell you what they believe happened is the heroin that folks were using was likely to have been cut with fentanyl or carbafentanyl, which is an elephant tranquilizer. But fentanyl, as you know, is used post-surgery or for surgery, and it's a pain reliever. It's very, very strong. Anyway, there's a lot of fentanyl that's being cut into heroin at this point, and they believe that that's what happened here in Huntington. Now, overdoses are not the only negative long-term consequence of this problem. There is another problem that we saw, I think, play out in national news last year was when Scott County, Indiana, had close to 200 cases of HIV in a county where they thought that they were only going to have about 5 that year. And it's actually pretty much all secondary to needle exchange and needle sharing, and tremendous negative outcome. What this slide represents is the 220 counties in the U.S. For which there's believed to be a very high risk or vulnerability to a similar outbreak of HIV and hepatitis C. This analysis that led to those 220 counties is published in Journal of AIDS. It's either published or I have a pre-publication copy. It's still double-spaced. I'm not sure if it's actually out yet. But this map is not in there. It's not in that actual article. But that's is a peer-reviewed piece that led to this finding. Hopefully you'll be able to disseminate that pretty widely soon. I think that in the top 10, I think the number 1 county, for example, is in Kentucky. But I think we have a couple of counties in the top 10, as does West Virginia, in terms of risk. Of course, as the Controlled Substances Monitoring Database has been mandated in Tennessee, and a number of other things have happened to control some of the diversion related to prescribed opiates. We've begun to see more and more heroin, and this is just a slide that was put together by the State Epidemiology Outcomes Working Group last year that points to the number of drug seizures, treatment admissions, and these are really treatment admissions for folks that are at 133% of the poverty level. Crimes, arrests, and poisonings, as you can see, they're all increasing in our state. This is just an illustration of what's happening with the crimes. The slide's a little bit dated, but you can tell from 2005 to 2012, There's a doubling in the drug-related crimes in the state, and a general decrease in non-drug-related crimes during that same point in time, and period of time rather. And then the next slide, neonatal abstinence syndrome is one of the most tragic outcomes of all this. Which these are babies that are born dependent on narcotics, and particularly opiates, and you can see in the eastern part of the state, we have the most babies that are born dependent, and there's been just a tremendous increase over the past several years. We are one of the few states that mandates reporting of neonatal abstinence syndrome, and that is thanks to our commissioner, John Dreisner, who's a true expert on this topic. Dr. Dreisner has basically made this a reportable condition, and we're beginning to get to the point where, our year-to-year reporting numbers are at least being done well, but what they're showing us is troubling. This is particularly hard to deal with for a couple of reasons. In some cases, in many cases, in fact, the substances that the moms are dependent on, and to which the baby is born dependent, are prescribed, and in some cases are themselves, used for the treatment of opioid use disorder, like buprenorphine. So in 2012, the prescription for 2013, the prescription for success was a document that, well, actually I'll talk about it in a few moments, but in that document there's actually this pyramid that illustrates that there's about a 5% need in terms of the whole Tennessee population, need for early intervention or treatment. And it's just a whole lot of people that are at this point in need of either some sort of early prevention type intervention or something that can get them back out of misuse. So when we talk about this problem, at least on our team, we talk about this problem as being complex and along a continuum, if you will. So if you consider the continuum of addiction or dependence or opioid use disorder from non-use to death, right, anchored on either end of that black line in the middle. And imagine the black line is sort of being ever increasingly harder to break, if you will. We haven't really illustrated that yet, but that's something that I think is true. It's harder and harder to change as you go down the continuum. And then the purple area is really dependent, and then past dependence you get into the frame of addiction, which is when you're really acting in a compulsive way to find the substances to which that your body craves. And then there's this concept of primary prevention. You can get people back out of early misuse, right? And you can prevent misuse, and you can even prevent initiation if you can get people to the left of that non-use side. And then the secondary is kind of moving people back over into the healthy state, and then tertiary is really rehabbing. This concept of quaternary prevention we're just playing around with the term, and the reason we say that is because this concept of overdose reversal. This is actually bringing people back off the couch after they've overdosed. This is where we are at this point with this epidemic. It's unfortunate, and frankly, it's an abject failure of public health and medicine that we've gotten to this point that we have to rely on naloxone to the extent that we do. But I'll take you around from the top all the way around, top left over sort of in a clockwise fashion. So we know that there are a number of interventions. In fact, if you go to the National Registry for Evidence-Based Programs and Practices at SAMHSA, there are 350 programs listed there that are effective primary prevention programs or prevention programs for substance abuse. we know that a ton of them exist. We just need to disseminate them and implement them better. We know, for example, that the prescription drug monitoring programs, or the Controlled Substances Monitoring Database, PDMPs and CSMDs, same thing. We know that those things work, but they work for a specific group. They work for diversion control, and those are people that tend to be either already dependent or addicted. Okay, and so those people who are doctor shoppers, for example, once a state implements mandated use of a Controlled Substances Monitoring Database, that begins to go away as a huge problem once states begin to do that. And so drug monitoring programs really do work. They're excellent. In fact, in our state, as you'll see in a few moments, we had pretty good success with implementation of the PDMP. Along the continuum here, traditional and medically assisted treatment. Medication-assisted treatment, meaning use of buprenorphine and or methadone maintenance therapy, while somebody can also gain access to therapy services, counseling services, job placement services, wraparound, things that can help them get their lives back in order. When they're done in an evidence-based way, and they're done in a very caring and thoughtful manner, you can have good success with keeping people engaged in treatment and keeping them from illicit substance abuse. And one of the things I think that needs to be pointed out is when people are engaged in either methadone or buprenorphine treatment, unless they are diverting that medication, then effectively you're taking them out of an illicit use situation, and in some cases even helping them avoid some criminal activity. So medication-assisted treatment and traditional recovery, like abstinence-oriented and abstinence-based recovery, those can be done really well and can be very effective, and there's good evidence for them. We know that naloxone is useful and has been demonstrated to be useful. It's responsible for saving thousands of people at this point, and I promote its dissemination and hope that more folks gain access to it. But again, I have to point out, as a primary prevention guy, it breaks my heart that we're at the place where our efforts are focused on naloxone in some cases. Drug courts have a tremendous success rate and cost benefit and return on investment, as we'll see in a few moments. This concept of addressing neonatal abstinence syndrome, particularly the concept of addressing NAS, the second NAS baby after a mom has delivered. So, after a few days after delivery, making sure she has the option to maybe gain access to voluntary, reversible, long-acting contraception. That's a treatment that we think should be promoted. Screening, brief intervention, referral to treatment. The literature on this one is largely in the alcohol realm, but it's also it's pretty strong there. It's beginning to emerge in the opioid use disorder or prescription drug abuse realm, but the evidence is not as strong there as it is for alcohol. And then finally, back to the left, the health professions training and continuing education. This one I say for last because it's absolutely sort of the crux of the matter. We have to do better with our health professions training. We got to do better at training our physicians, our nurse practitioners, our PAs, and other prescribers, as well as our pharmacists, dispensers, to address this problem. And I don't mean just from the prescribing side, but also mean from the dispensing side, making sure that folks in the pharmacy arena actually have the access to a number of tools that will help them point somebody toward adequate treatment if they present in the pharmacy, for example. So we've been accumulating evidence for these different approaches for a while, and recently started looking at return on investment and sort of cost recovery and things of that nature. But on the primary prevention side, you can see that there's an 18-to-1 ROI and that is if there's really wide-scale adoption, such as could be done in schools or other primary prevention type settings for younger folks. In Tennessee, we saw a 36% decrease in doctor shopping when the controlled substance monitoring database was put forward and mandated. We actually, for medication-assisted treatment and others, other types of treatment, there's a 7 to 12 to 1 ROI. Naloxone is a little difficult to talk about because actually, you have to disseminate a lot of it in order for it to be effective. One study we've seen said that there's about one save for every 227 kits that are disseminated. So from a cost-effectiveness perspective, that one's interesting and harder to argue. But when you see an example of the overdose little cluster that happened in Huntington on Monday night, you can see what the real value of disseminating that pretty widely is. In terms of drug courts, there again, 2 to 1 ROI, and then Verlac is a 5 to 1 ROI. The experts looks like if you can get folks to get engaged early, then from the employment side, then you can have a pretty good return on investment there. Then the last one I want to point out is that there are a ton of prescribing guidelines and tools that are emerging as we go further along down this epidemic problem. You can see the prescribing opioids for chronic pain guidelines that came out this year, the national practice guidelines for ASAM. Just discovered this one yesterday. A colleague sent it to me, interventions for community pharmacists about how to talk to your patients, for example, about substance use disorder. And this is a real issue. I mean, a lot of pharmacists don't feel like they're well trained in this, and it is a point of access to patients where they can really have a tremendous impact on that patient's health and safety in their home, including, not the least of which, is how to store Schedule II, Schedule III narcotics in the home, particularly if you have folks who might be drug seekers or others that could have access to them. And finally, I also want to point out ASTO's got a nice webpage with a lot of evidence-based strategies for prevention, for monitoring, for surveillance, diversion, and treatment. So I recommend actually, if you're really interested in this, ASTO's, there's a lot of information in this one place on their website. It's under programs, then under prevention, and then under prescription drug abuse and misuse. One of the perspectives that's put forward by our commissioner in Tennessee is the concept of prevalence really being the area inside the big triangle on the left, okay? And then prevalence being a function of prescription drug supply, demand, and then potential demand. And then if you shrink any one of those lines, then you can begin to have an impact on prevalence. But in order to have a large-scale impact on prevalence, you're going to have to shrink them all. And I guess you could theoretically shrink one of them and decrease it tremendously. But the point being, you can minimize prevalence if you were able to shrink them all. So this is a concept that he put forward a number of years ago, but we keep it in mind because it's helpful to remember that there are significant economic drivers to this problem, and not the least of which are drug companies, prescribers, an entire industry associated with this, and many other aspects of it. one thing I want to point out is that with respect to state policies, it's hard. There are a number of model policies that you can look toward, but every state is slightly different in what gets put forward and how it gets put forward. They're often, real specific to the context of that state, and sometimes interdependent on other things in the state. I want to point out the effect of a couple of them, though. A couple of good policy studies were done. One, this was on basically trying to change pill mills, which were pain clinics, and in Texas, and they like in Tennessee saw a lot of impact with high volume prescribers. This next study is really interesting because this showed over time what happened after Florida began to institute different things. And Florida, many of you may perhaps you don't know that back prior to 2010, when these different policies were implemented, there was just a huge increase in pain medication dispensing. And there's often, if you're watching cable late at night, you'll see one of these documentaries on what was happening in Florida at the time. And a lot of people were opening up pain clinics, making millions and millions of dollars, and just basically operating pill mills. And so what Florida did was they got real serious about this, and they instituted a number of different things. You can kind of go down the A, B, C, D, E, F, and G and sort of see what they did at different times. So the pain clinics had to register in 2010. Then they did Operation Pill Nation, and then the pain clinic regulation was expanded, and so on and so forth. Then the raids began, and then you can begin to see the real sharp decrease after C. C, D, E, F, and G is when they really begin to have a tremendous impact. And like in Tennessee and in Texas, if you look at F, September 1, 2011, mandatory reporting to prescription drug monitoring programs began at that point, which was what happened in Tennessee in 2012. Active in 2013 was the Prescription Safety Act, where physicians, dentists, prescribers basically had to check the state's controlled substance monitoring database for a patient's history before prescribing any painkiller or tranquilizer. And then that also has implications for pharmacists and when they check as well. Then there was a large report on things to do, statewide strategies to prevent and treat the prescription drug abuse epidemic in Tennessee. This was 2013 document, I think, the Prescription for Success. And that really, a lot of different activities began taking place shortly thereafter. This next slide is very interesting because it illustrates the extent to which the state is treating this as a complex problem with a lot of different drivers. I can't speak to any individual piece and what's happening at this moment from the state perspective. This isn't our team's perspective, but it is was adopted by the state, as you can see, in early 2016, and it illustrates the seriousness with which they're taking it, from the primary prevention to the monitoring and surveillance to regulation and enforcement, to secondary prevention, and then increasing access to appropriate pain management, including multiple different types of pain management. So you can see what some of the different strategies are there, as well as some key, principles to keep in mind all across the bottom, cross-cutting, if you will, principles. I think this is a slide that illustrates well. Also, that there are a number of folks in Nashville with tremendous expertise that are taking this very seriously. Our current situation is, I say sharp decrease. I need to modify that to decrease in overall prescribed MME in Tennessee. It corresponds in timing with the advent of the PDMP, mandated use of the Controlled Substance Monitoring Database, or the PDMP. There's been a steep decline in prescription drug seizures by police, and that's not including buprenorphine. Overall, our milligrams morphine equivalent volume is down in Tennessee, but overdose deaths continue to increase. Heroin and Suboxone and buprenorphine seizures are increasing, and there's a tremendous increase in the diversion of buprenorphine. And I can speak to that specifically. In our region, we have, I think, around 115 prescribers of buprenorphine, and there's a sort of stated version of this diversion problem that is, where the prescriber will give a fair amount of Suboxone, and some of it will be sold in order to pay for the prescribing physician's next visit. So, or the next visit to the physician, and this increases the stigma with law enforcement with respect to MAT, as you might imagine. Also, Suboxone is basically welcome if it's done well, and that's the thing that we're really trying to hammer on at this point. Our data systems are strengthening. We have pretty tremendous engagement from the governor on down. I mentioned the cabinet expertise. Our commissioner for mental health and substance abuse services is also an expert on this topic, and he works closely in collaboration with our Department of Health Commissioner, Dr. Dreisner. The good news is they're taking this very seriously, and we're beginning to make some inroads. Importantly, conversations are beginning to happen much more often. I'll tell you recently, partly because of our ongoing efforts to start this opioid treatment program in this region of the state, but partly because of the scope of the problem here, we've recently had a series of articles in the paper on the opioid wars, and it's been very, very interesting. I will tell you that the amount of stigma associated with opioid use disorder and just substance abuse and mental illness in general is just tremendous and troubling. In response to this problem, in 2012, a number of us got together and began sort of a monthly gathering where we just sort of think out loud about what everybody sort of talk out loud about what we're doing, and think out loud about how we might be able to connect. It's kind of like a coalition, but it's not really. It's a group of researchers and a group of coalition members and concerned citizens and physicians and others. Just kind of getting together to brainstorm about how to have a greater impact. And we just keep adding to the email list. We have about 140 plus, maybe 150 by now on the email list. We have 20 to 40 that attend every month with a highly interprofessional focus. We early on we really focused on research, but we have I think a greater focus at this point on community outreach, education, and resource development. But importantly, the folks that are in the room tend to be read up on the scope of this and the fact that multiple systems have to be impacted in order to change the scope of the problem over time. We sort of look at it like this, and apologies for the kind of confusing looking diagram. We sort of look at it like a fertile breeding ground for a lot of new ideas. We've had a lot of success getting projects funded and moving. We have a number of proposals that have either gone under review recently, or we've learned, unfortunately, that they weren't funded. But the idea is that there's a lot of things bubbling out of it that are basically going to lead to the next new idea. At this point, it's actually large enough where I believe that we're going to need to refocus perhaps a research arm of it because it's beginning to get a little bit unwieldy. You can see here sort of the range of folks that come to it and sort of what their affiliation is. And then Alice, one of our coalition partners speaks highly of it in this quote, saying that it keeps her, it helps her when she's feeling stuck, and it's restoring and energizing. I agree with that sentiment because often, it can be frustrating to work in this field. There's a number of different things that we've been doing in order to not just focus on research, but also get public health programs, evidence-based public health programs on the ground where they're needed the most. And one of the things that has come out of it is we felt like if we could organize into a center, then over time we could begin to map individuals from the center back onto different evidence-based approaches. Okay, so the center that was approved in April basically has an admin core, administrative core, patient care core, research and evaluation core, and an education and outreach core. And so what we've done is we've partnered with our largest local hospital system, Mountain States Health Alliance, and the largest provider of mental health and substance abuse services, Frontier Health. And basically we've proposed a recovery-based treatment facility that will be an outpatient opioid treatment program in sort of a centrally located space between the Tri-Cities. It's about kind of a suburb of Johnson City. It's in between Johnson City and Kingsport and south of Bristol. But the idea there is that in the course of treating folks using medication-assisted treatment, primarily methadone to start, but also Suboxone later, in a strong evidence-based way, that over time, as that clinic begins to realize some revenues, and that those revenues will be reinvested back into the center because that entity is a nonprofit collaborative between the university and the hospital system. So that's where we are at this point. We've proposed the OTP. It's under review with the state certificate of need, Health Services Development Authority, and that's where we are right now. That we actually will get a vote on that next Wednesday. You might imagine there's a fair amount of controversy for where we placed decided to place it in terms of the proposal, and that has not been without its drama is too trite. I don't want to put it that way. There have been some feelings of animosity generated from that, and it's really unfortunate. But I think it's fairly common when it comes to the topic of methadone management therapy. So the last slide or two here. If we're going to have an impact on this, we're going to have to do a lot of stuff at once. We need to push back against all of these things, and not just one of these things. And that's why I do get discouraged if I see, a large-scale implementation of just one type of program, be it medication-assisted treatment, or be it diversion control, or be it naloxone, or drug course, or just arresting our way out of this problem. If you go to the Huntington Dispatch, or whatever the newspaper was in Huntington, there's a little poll that you can take at the bottom after you read the article, and it says, well, okay, so given that we had 26 overdoses in Huntington, West Virginia on Monday, what do you think should be the number one thing that we focus on? Stiffer, harsher punishment for drug dealers, better access to treatment services, or prevention? And it's 3-1 for harsher punishment and more law enforcement crackdown on this issue. And really, we all know that it's not any one of those things; it's all of those things, and we need to push back on this in a systematic, coordinated, and focused way. Our center staff and faculty as we shape all this up and get everybody assigned to different places, there'll actually be assigned different ones of these blue boxes to attend to with respect to the dashboard in our 11 county service region. And so the idea is that we have a constant update on what's actually happening with respect to overdose reversal with naloxone or naloxone distribution programs and MAT and so on and so forth. And we get this really good data system in place and then can share that to push back against this problem in a coordinated way. So finally, I just want to point out that the problem, these are the key lessons here. The problem is actually much bigger than we anticipated. And I gotta say, even coming into this from a public health perspective, earlier on than many, it's even bigger than I anticipated. And one of the key reasons why is that people don't have volitional control over their behavior past some point early on in the continuum. And when you don't have control over your own behavior, there can be some tremendous problems. There are also some significant supply side drivers to the problem, including the whole industry that profits off of pills in terms of prescribing and dispensing. Then there's a tremendous amount of fragmentation with respect to the problem. I think that we can do a lot more in terms of our state and other states to coordinate efforts around this. A concrete example of that in our state is that our coordinated school health infrastructure is tremendous. We have about $15 million a year that's spent on coordinated school health coordinators in the state, and I believe that we could align those resources with this topic at least for a while to begin to push back on the primary prevention side. I think policy is absolutely fundamental. States have to do this well, and sometimes they run up against policies that are put in place that are directly antithetic to the best evidence, or in the face of in spite of, in some cases, the best evidence. But we have to encourage strong policy. We've learned over time that politicians and elected officials are very much concerned about the workforce and people being able to pass drug tests. And at that point, you can get them engaged. And there are evidence-based workforce health promotion strategies, one of which we've been using here is called team awareness. Another key learning here is that it really helps if you are out and talking to folks and in the community and showing up. One of the things that I think really helped in terms of the working group is we began to have our meetings on campus and off campus. We alternate, and we try to get more connectivity to the community every chance we get. There's a huge amount of stigma still regarding addiction, and that keeps coming up and keeps coming up. And also, just if you're going to be working in this area, openly acknowledge that and know that there is a lot of tension in the recovery community on both sides, for and against the use of medication as people try to recover from this tremendous problem. So that's the end of my remarks. I will gladly take some questions at this point.
Rob, thank you very much. That's really a great summary of a complex issue. We're now able to open the call up. Please, folks, after you ask your question, mute your line and don't put us on hold because we get to hear your background music then. You can also type in questions into the chat box if you prefer. So, folks, anyone like to ask a question?
Dr. Goodkin has his hand raised.
Yes, Rob, I think that was a great presentation, and it raised a few things for me that I thought I'd like to hear more of a comment on. One is just in terms of the perspective about prescribed opioid use disorder generally, looking at it from the point of view of a lifelong illness rather than something that people are in control over. And I think you came to a point in the end where you were focusing on that aspect yourself. I think that's a very important differentiation to be able to make about this that we need to be able to promote in the community. And further, related more specifically to what treatments are planned, to be provided, I was hoping for more detail. One thing about treating these disorders after the use of methadone and buprenorphine, both of which we hope to be temporary, we try to institute medication and behavioral intervention to prevent relapse, and medication that's been useful is naltrexone. You've talked a lot about naloxone in the setting of acute OD, but I think monthly naltrexone is a very useful treatment to prevent relapse, especially when used in conjunction with behavioral interventions.
Yeah, that's a very good point, and you're absolutely right. I did not talk about naltrexone in this talk, but it is one of the medications in the list of medications associated with MAT, the whole field of MAT, and it's absolutely very much evidence-based and effective. Can be somewhat pricey, but the alternatives are much pricier. So I fully agree with that. I think it's a very good point. Now, with respect to a lifelong problem, this actually comes up in a sort of an unusual way. What happens if you're a prescription painkiller addict and then you need prescription painkillers at some point? Say you break a leg, you've fallen off of your roof, for example, or something, and you've got an injury. And this actually happened to a friend of mine, a very dear friend of mine, in fact, who had an opioid use disorder problem and did have an injury that required some medication. So what happens at that point? And what are the systems really set up to help a person in that case? I think that they require a great deal of care at that point. And really, to the third point that you made about details regarding the OTP, I'll tell you, we've visited OTPs, and there are a number of regulations. We visited MAT facilities. There are just scores and scores of regulations that are basically set up for how you run those programs. And thankfully, Dr. Goodkin, I'm not going to be the person that has to run our OTP. That's going to be a clinical care team. I'm the center director and going to focus more on the research side. I'll be on the board that will effectively talk about how to get some of these things done. But we're many months off from having those all of those details in place.
And so, given the time, maybe one more question from the audience, and then Rob, would you be willing to share your email address with folks so they could send you questions after the fact?
I'd be glad to. My email address is packr@etsu.edu. Trying to.
Rob, any last question for Dr. Pack? All right. Well, Rob, thank you very much. Thank all the audience members. Is there anyone who's new to the call who would like to introduce themselves or their organization? All righty. As always, I extend an invitation to everyone to let us know on topics you'd like to cover on future calls. You can reach the ASPPH folks, the ASTO folks at the address that they gave you. Just to let you know, tomorrow, August 19th, is the next Successes and Measures Committee call. It will be 2 to 3 p.m. The call will feature a presentation from Dr. Stephen Cha, Director of the State Innovations Group, CMMI, as well as Elizabeth Walker Romero, Senior Director for Health Improvement at ASTO. Anna, let me turn it back to you if there's any last business items.
We have no more business items. Again, please feel free to email integrationforum@asto.org with any questions or ideas for future webinars.
Well, thank you all. And thank everybody. And Rob, thank you again for an outstanding presentation. Talk to you all next time. Bye-bye.
Bye.